Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. We are recording this podcast on August 17th, 2020, while public health efforts continue in an effort to control and slow the spread of COVID-19. In the last couple of weeks, we've discussed the development of vaccines in an effort to treat COVID-19 and prevent it. We've discussed ramifications of returning to school. And today we're here again with more updates. I'm pleased to say that I have with me again today Dr. Greg Poland, virologist and infectious disease expert at Mayo Clinic. Thanks for being here, Greg.
Yeah, fun to be with you again.
Well, I am looking forward to hearing what you have to say to us today.
The news keeps coming out. We are in the US now at about 5.5 million cases with over 170,000 deaths. We still have prominent outbreaks, particularly in Florida, Texas, along the southern and southwest rim. Schools are starting back, and we've heard of outbreaks at the college level, the school level. Most recently, LA County, which is I think the second largest school district in the US, decided to cancel any kind of in-person classes as they try to get a hold on this. But there's something interesting to note. New York and New York City in particular have kept cases suppressed below 1%. Now, this is really remarkable, but observers are noticing that because of what New York City went through, they don't deny the seriousness of this, and people take it very seriously. They're wearing masks, they're maintaining distance. They closed, bars and things like that where there are known places where the virus easily transmits, and it works. As you know, I was on Mayo campus last week, and it was a remarkable thing to see, 20,000 staff and doctors and patients in our facility, but everybody distanced, everybody wearing a mask properly above their nose, screening questions, hand sanitization stations, and it works. Those are together simple measures that have been terribly effective. And somehow it's been difficult to convince our culture, our society, that strict adherence to those things in toto, that is doing all of them together, is a very, very powerful antidote to this virus.
What you said about some people are in and some people are out. I saw multiple articles actually in the national news this morning about why do some people take this so seriously and why are other people having difficulty or denying it?
Yeah.
And we certainly are having some large outbreaks in certain areas. You and I talked about vaccines last week, Greg, and today I wanted to ask you about the concept of herd immunity. We've touched on this briefly in the past, but now we've had some really big outbreaks. I'm thinking of the outbreak in the San Quentin prison, for instance. What do we learn, or what can we learn about herd immunity from situations like that and from other countries who are a little further ahead of us in the
that's a great question. The San Quentin pandemic is really instructive. I was just looking up the numbers. They've got just under 3,300 residents in that facility, and 2,200 of them have been documented to be infected. They've had 25 deaths. So what that means is that 2/3, a number about where people have been talking herd immunity would happen, 2/3 of those inmates were infected. And yet in the last 2 weeks, they've had more than 60 cases. So this tells us that in close quarters, now, that wouldn't be reflective, for example, of a medical clinic or, some other experience, but it would perhaps be more reflective of a dormitory, of crowded school hallways, things like that. And it's apparent that herd immunity isn't occurring that way, that in fact, that number is likely to be even higher if that concept exists with this novel coronavirus. In fact, if you think about it, if you took those numbers, and it's kind of inappropriate to do so because the US, isn't a prison in that regard, but if you took those numbers and you translated that to the US population, that would be about 2.5 million Americans dead. So this concept of just open things up, forget about it, let's approach herd immunity. is definitely a false one. In fact, we've heard this with Sweden. And I went in and did the homework, looked up the numbers as diligently and carefully as they're reported. You know, Sweden has had a death rate almost 5.5-fold higher than Denmark, 9.5-fold higher than Finland, and almost 12 times higher than Norway. And yet their population seropositivity is only about 7 to 10%. So the cost of saying we're just going to let everybody get infected would be enormous in the toll of deaths and still not get us there. So I think our job, yours and mine as physicians, as educators, is to, one, be knowledgeable about the data ourselves, but two, be those reasoned voices that are telling people, look, this is what the science is showing us. We can protect ourselves. We can decrease the length of time that we're going to be under these conditions. We'll get a vaccine, hopefully within the next 6 months to a year, and we'll be better off if we just cooperate together.
And the responsibility of our viewers and listeners as well to mask, to wash hands, to socially distance.
Exactly.
That's a good reminder. Say, yesterday, Greg, I stopped in a local restaurant here to have lunch, and I was asking for a table outside, and they have their tables nicely distanced. And they asked me for my phone number when I checked in, and I said, oh, is the wait that long? I don't know if I really want to wait quite so long for a table. And they said, no, we're collecting phone numbers in case there's an outbreak of any of our workers in our restaurant, or we hear of a guest, for contact tracing data. And I'm wondering, what can you tell us about what kind of work is going on in that arena and what we're learning from it?
First of all, that's very sophisticated thinking and planning on the part of that restaurant. When you look around the nation, what we're hearing from state public health departments is two difficulties. One is getting a hold of people. Phone numbers are outdated or not available. And so they can't actually contact trace because they can't contact people. And the second one is, even when they do, there are a fair number of people who don't want to divulge who their contacts are, making contact tracing, null and void of its power. On the other hand, there are some states that have managed to do this well. And when you do it well, you're able, particularly in the early stages of an outbreak before it's just, running rampant, you're really able to contact these people, talk to them about the importance of quarantine, and dramatically suppress the caseload in that community or in that state. So contact tracing is really helpful that way. It also tells you something else. Who and what age individual? Where are they getting infected? Is it schools? Is it community? Is it bars or restaurants? All of that is very, very helpful in formulating public health policy. So it's something that I think in the US we were slow to do. Now state health departments at various levels are doing it. I think the next stage is to get those data out on public health sites so that the public can see what is the risk in my community and what are the appropriate measures to take, and then see that it actually works.
Greg, you and I have talked previously on another podcast about how Mayo Clinic uses contact tracing for our employees to help prevent the spread of COVID within our employee group. And I also was thinking about how important that has been educationally. So working in public affairs, we do a lot of education of our patients, of our employees as well. And to be able to share with employees how their behaviors might have had an impact on others is really very interesting and essential, I think.
Yeah, well, you make a good point, Helene. It's really kind of a feedback loop, isn't it? Not only does it decrease cases, but you can tell by your collective behaviors that it's having an effect, and you can see the numbers. And I think it's a fabulous thing to do. We know it works in epidemics and pandemics. It just needs to be done.
Months ago, I had actually heard that when the Amazon boxes come to the house, you should be careful because the virus can live on surfaces for a period of time. And then there's been concern within some food packaging plants about the spread of the virus, perhaps not just in the food, but via the packaging. And I'm wondering, what can you tell us about how to handle food packaging? Is that something we should be concerned about? Should we be wearing gloves to the grocery store? Should we be wiping off our groceries?
Yeah.
What can you tell us about that, Greg?
Good practical questions. First, maybe just a little bit of a primer here. So the fact that you can find virus by PCR doesn't mean, so to speak, that it's live virus. It just means elements of the genetic material are there. The second thing is, it doesn't mean that it's infectious virus. Part of what infects us is the inoculum, the amount of virus. So, for example, it's highly doubtful whether one particle of virus could actually cause infection. No one knows what that inoculum size is. All right, so what has been done is a number of studies showing that you can find the genetic material for days, sometimes even weeks, on various kinds of hard surfaces or external surfaces. The ones that are at risk are where there's high inoculum size. I go, and then I grab a doorknob and you're right behind me and grab it. We think that's logically a risky thing because we know with other respiratory viruses like influenza that you can infect other people and get infected that way. No one has proven that with food or with external packaging. That's different than the hard surface in a hospital room, for example, where that inoculum size might be very high if it housed a COVID patient. So first of all, I think we can say there's not been a single demonstration that viruses on food then infect somebody, or on a package then infect somebody. You think about the route of, let's even take something like an expedited shipping where it's 24 hours. Nobody has shown that somebody has become infected that way. Now, people then ask me, well, is there any harm in wiping my packages off or putting them out in the sun? None at all. And I think, it's a margin of safety, even though we don't have any proof that that is a direct risk. But I don't discourage people from doing it. Where I get more concerned is when people say, well, maybe my food isn't safe. And there just isn't any evidence for that. There isn't evidence of that for other respiratory pathogens either. And I think that's particularly true where food is cooked. I just don't think that that's a logical route of infection.
You've been giving us updates all along on the vaccines that are being developed and how many have enrolled, et cetera. Can you tell us how the vaccine trials that are in phase 3 are going right now?
Yeah, so the phase 3 trials that are occurring in the US have enrolled slower than thought, at least last week. Remember, they have to enroll 30,000. They had enrolled about 4,500. Now, only roughly about 59, I think it was, of the 84 clinical trial sites had opened as of a week or two ago. So I expect that will accelerate a little more. But when you think about it, those first participants that enrolled, let's say early August, you have to wait 30 days, then they get another dose. 2 weeks after that, they get a blood draw. Then all of those hundreds of thousands of laboratory assays have to be done. The data has to be analyzed, et cetera. You're talking well into 2021 before those data would be available, could be looked at by the FDA and by expert advisors. So I think realistically, and we've said it all along, unless another mechanism is used, if we go through full licensure, I don't think we should be looking for a vaccine for another 6 months, and for some people, because of the time it takes to manufacture doses, a year even. So I think we're in this for the long haul. Again, as we've said from the very beginning, that in fact, somebody was joking with me where they said 2020, oh, that's right, year 1 of quarantine. And, it's kind of gallows humor, but it makes the point. If we can suppress cases, draw this out slowly, because we don't have any other preventive measures until we get a vaccine, and hopefully we get a safe and effective vaccine, get it administered to people as quickly as possible, we'll be able to begin truly relaxing these, but not until a vaccine. Even when you suppress cases, if you start relaxing that prior to a vaccine, we have seen that outbreaks will start again.
I had shared with you that I had seen an interesting study done, which I thought was actually rather well done, where they compared masks and how effective they are. While we're waiting for that vaccine that unfortunately is taking longer than we wish, we're protecting ourselves and protecting others. And I had read about 4 different types of masks and their efficacy, and I was hoping that you and I could just talk a little bit about them today. Sure. I have examples on my desk here to show, and I have a gaiter on myself right now. So if you can start by telling us about gaiters.
Yeah, so the latest data, and actually this was just last week in a study published in Science Advances from a group, I think it was at Duke, used some pretty simple equipment. And remember that the goal of their study was to say, if I had a mask on of various types, how many particles escaped that would be potentially infectious? So they didn't prove infection. They're just saying, with normal people talking, I think they were saying, healthy people stay healthy or something like that. So with just that, they weren't yelling, singing, anything like that, just speaking, and how many viral particles escape. So, they all escape if you don't wear anything over your mouth, right? So not wearing any kind of mask is foolish. You are exposing other people to virus if you're infected, and most of the time you won't know that you're infected, which is why it's so important. Next, they looked at the various neck gaiters. I have one too, and these are very lightweight. They're kind of a stretchy cotton. If you held them up to the light, you can see through it. And what they found is that really did not decrease the number of large viral particles by very much. And in fact, they found something worrisome. And that is, by expelling the particle through the material, it actually served to take the big particles and fracture them into more dangerous, smaller particles. So these masks don't prevent you from expelling virus, and in fact make it riskier for other people. So this is not an appropriate mask to wear. Next, they tried bandanas, a double layer of a bandana. That decreased the number of particles, I think, by about 20, 30%, something like that. And if we go to some of your other props there, I brought one. My wife made this mask. It's 3 layers of cotton. Now, all the Duke study group studied were 2 layers of cotton. But almost all the other materials that they used decreased the release of particles by anywhere from 60% to 90+% when you get to some of the masks you have there.
Yes, I also had a cloth mask to show you. It sounds like these neck gaiters, we should probably just say for warming our necks in the wintertime and not count on them for masks. And then, Greg, this is the most common type of mask. You showed us how to put this on last week that you and I would wear while seeing patients. We call it a surgical mask. It's a paper mask.
Yeah, so that's a 3-layer paper mask, or so-called medical or surgical mask. Those are surprisingly good, worn properly. They're not perfect. There is even the N95 is not perfect. Hand washing isn't perfect. Physical distancing isn't perfect. But together, they're about as perfect as you can get, as it turns out. So you're probably reducing the expulsion of viral material by about 95+% with that 3-ply surgical mask. That's a very good mask, worn properly.
What about N95 masks? These are the masks that are used in the hospital when we know that we have a patient with COVID, or when there's a high risk of potential transmission. Yes. Does everyone need to wear one of these?
So those masks are very, very effective. They filter, it's called an N95 because it filters out 95% of viral particles at its least efficient point. So it's actually better than that, but when it's least efficient, it's still 95% effective in that. The problem is this: has to be fitted properly. Now, I have a short beard. Other people have longer beards. You really can't fit it well with a lot of facial hair. And it takes some experience and an experienced person to fit it. The other thing is, inside a medical facility or indoors where there's air conditioning, air exchanges, they're reasonably comfortable to wear. Outside, I personally don't see how I could wear one more than an hour, maybe 2 hours, because they are tight. They are kind of constrictive. If you wear them too long, the exhalation begins to get the mask wet, and a wet mask is not an effective mask. So probably not something that the general public is going to be wearing usefully.
Greg, I don't have an example of the last one that I wanted to ask you about, and I don't think they mentioned it in the article that we were discussing, but I have seen people wearing masks with the valves on them.
Yes.
I think to allow their own carbon dioxide to escape.
Yeah,
correct?
yeah. So the valved N95s are not as effective as the N95 mask. It's certainly better than nothing, certainly better than some of the cheap 1 or even 2-layer cotton masks. So there's no harm in wearing it, and there is benefit in it. But the presupposition behind the mask is a faulty one, that somehow CO2 levels are going to build up in me. There is no evidence for that. As you know, as healthcare workers, we wear them for hours at a time, and healthcare workers are not keeling over with carbon dioxide poisoning. But I think some people maybe find them a little more comfortable in terms of letting out some of the moisture, but whatever can go out can come in. And that's why you never see a healthcare worker wearing a valved N95 mask.
So I had looked on the CDC website to see what they said about various masks, and they said you should not wear a mask with a valve, right, because essentially all you're doing is pushing out your virus to
right,
others and
right,
not providing the protection that the mask typically would. This has been fun. Thank you. We compared our gaiters today. We'll save them for fall for a fashion accessory. Thanks so much for being with us today, Greg.
My pleasure.
With us today has been again infectious disease and virology expert, Dr. Greg Poland from the Mayo Clinic. We appreciate him being here to share updates with us, and we appreciate you listening too. Have a nice day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.